Hi, everyone. So welcome to this live webinar today. My name is Luis Valiño. I'm the International Area Manager here at BioArray. So I will be the moderator today. So essentially making the presentation. So just a couple of minutes of introduction as all of the people who registered join. So I can see that some of you already know our company, BioArray. For the ones you don't, just a few words. We are a genetic testing provider. We've been working with chromosomal microarrays and sequencing, both Sanger and next generation sequencing for more than 12 years now. So great experience with all sorts of Mendelian disorders, including germline cancer mutations. And also for some years now, we have been, adopting the latest breakthroughs with NGS, also for solid tumors and liquid biopsy, which are our topics today. Okay, so now let me introduce the key person today, our speaker, Dr. Noemi Ribes. So a few words on her. So after graduating in biology, she obtained her PhD in 2016 at the Institute of Neurosciences. This is within our National Research Council in Spain. There, she worked with tumor suppressor genes involved in the development of glioblastomas. All right. Then she moved to the USA, where she worked as a postdoctoral researcher at the University of Michigan. There, during 4 years, she worked on stem cell and cancer genetics research through multiple approaches, from transcriptomics to epigenetics. And nowadays, she's our head of research and development at BioArray, including managing the cancer genetics at the lab. All right. And now, finally, just a couple of words on how the webinar works. So on your screen, you will have Noemi's slideshow. And only on the right-hand side of the screen, you will have an area for the chat. There is where you can type any questions you may have at any time during the presentation. And at the end, we will try to address as many as possible. Noemi will answer as many as possible. And finally, as I'm speaking right now, I will enable this, let's say, pop-up on the right-hand side as well. This is for you in case you want to request a call with us later on to get further information. For instance, on the test list, the gene coverage, the gene content of the test, how we collect the samples, anything. All right. So again, you can click on that button during the presentation or at the end. And well, that's it. I give the floor to Noemi. So enjoy the webinar.
Okay, thank you, Luis. I think it's my turn now. So I'm going to start with the presentation. So first of all, welcome everybody. Good morning, and thank you for being here with us, sharing your time. As Luis just said, I'm Noemi Ribes, the head of Cancer Genetic Department here in BioArray. And today I'm going to show you, or I hope to show you, the catalog of tests that we have put together in order to assist cancer genetic diagnosis and treatment selection. So without further ado, I'm going to go ahead and start with the test. So as probably all of you already know, cancer genetics studies are a really powerful tool for us, because knowing the landscape of underlying mutations that might be on a particular type of tumor can help us to make a proper classification of the type of cancer, and better know the type of tumor that we are fighting against. Also, some of mutations can help us to gain insights into the prognosis of the tumor and also how the cancer might end up behaving. Finally, and which is one of the most interesting things, is that knowing the mutations and particular type of mutations are really helpful for us to better select the best fitted treatment for the particular case of the patient. And in the case that there are unfortunately no treatments available, also we will let you know different clinical trials that are going on, and you might end up considering including patients in clinical trials. So also, as you can see here in this little graph, cancer research is a really productive field that offers constantly new actionable targets drugs, and clinical trials for better cancer management. Altogether, has opened the doors to offer more than ever personalized case study to select the best fitting treatment for each patient in order to improve their chances of survival and disease-free status, which is what we would like for all of them. So here in BRA, we offer solutions for cancer genetic assessment based on one of the reference technologies in the field, which is the next generation sequencing, in order to assist cancer diagnosed and treatment solutions. Our goal is going to be always to offer the best test to assay key target genes with proof relevance in cancer, but also deliver to you, the specialist in cancer, clear and easy to interpret results about the mutation landscape in each sample and the best fitted treatment recommended by regulatory agencies. All information that we include in our reports, it keeps constantly updated with the new discoveries and publications regarding cancer science, and also information that feed us from industry and pharma companies. And again, without further ado, I'm going to go ahead and show you the catalog of tests that we have put together. In the way that we have organized these is three main groups. The first group of tests are the ones that are intended to make a genetic assessment of solid tumors through tissue biopsy samples. So with that in mind, the first test that we have here to offer is the Pan-Cancer Comprehensive Assay Plus. This is a test that has been thought or has been selected in order to be able to give you a genetic screening for whatever type of solid tumor type, independently of the tissue of origin. So this is a pretty wide and really big panel that in theory will be able to assist you with the screening for mutations in whatever tumor, as I said, independently of the tissue of origin. As you can see here, this is a really big comprehensive panel, including more than 500 of genes, where we will be able to assay different type of lesions, from single nucleotide variants, indels, to change in the number of copies of a particular gene. Also, because we only not include DNA, but also RNA, we are able to explore also gene fusions and also splice variants. Besides of that, one of the most interesting things, or one of the key important things in this test, is that we are able to also provide information about two really interesting biomarkers regarding to immunotherapy, which are the tumor mutation burden and the microsatellite instability. So, yeah, as I said, through one piece of tissue biopsy, we will be able to get not only DNA but also RNA to assay all the type of lesions that I just mentioned before, and also to provide information about these two key biomarkers, the tumor mutation burden and the microsatellite instability. So in this case, depending on the type of tumor that you are trying to assay, these two pieces of information might be really relevant for your case study. So one thing I want to point out is, besides the fact that this is a really broad or really big panel, the 500 genes that are included have been carefully selected because they are relevant for cancer assessment and cancer management. I'm not going to go with a lot of detail, but as you can see here, we include genes in the homolog repair pathway, the well-known Braca1 and Braca2, but also we don't leave behind genes that are really important for treatment selection. We explore mutations in EGFR receptor, but also mutations in BRAF and KRAS or HER2 genes, which have been proved to be really relevant for different types of cancers. And also we, as I said, are able to assay fusions as ALK or ROS fusions, which are really important for treatment selection in different types of cancers. I'm not going to go with a lot of detail here. This is just a bunch of tables where we have included the 500 genes that we include in this panel, and they are just organized depending on the type of lesion that we are able to assay in each of them. So in here you can see a list of genes where we will be able to assay hotspot mutations or changes in the number of copies, gene fusions, and all of them. I'm not going to stop here because for sure you will have this information available in case that you need it. So again, a bunch of tables just listing the 500 genes and all the deletions that we will be able to assay in each of them. The next test is this pan-cancer comprehensive assay, which is kind of a little sibling from the previous one. I say this because in some sense it's similar because it's a test that has been selected or designed to be able to perform a screening for whatever kind of solid tumor independently of the tissue of origin. So with one test, you will be able to almost assay whatever solid tumor that you might want to be interested in, make a genetic screening. The main difference of this one and the previous one is, as you will see in a minute, is that this one is a little bit smaller in the number of genes that we check. And also, we do not include the tumor mutation burden and the microsatellite instability assessment. So these are the numbers. In this pan-cancer comprehensive assay, we go ahead and check 161 of the most clinically relevant genes. Again, through a piece of tissue biopsy, we will be able to get DNA and RNA, checking for hotspot mutations, indels, changes in the number of copies, but also gene fusions. Exactly as before, I'm not going to go with a lot of detail about the list of genes because you will have all of them available, but the selection of genes has been made thinking to have a great coverage of DNA repair pathways and also cell cycle pathways, and for sure genes, as I said previously, that are really important to assay mutations on those genes because can help us to better decide on treatment selection, as might be again EGFR receptor or fusions in ALK, ROS, and many others. So again, as previously, these are the tables showing the 161 genes included and the type of lesion that we will be able to assay in each of them. Just to take away with you, the main difference, as I say, is that even if both are designed to be able to make cancer screening of whatever type of cancer, solid tumor, the main difference is these two markers that in some cases might not be relevant for the case of study, and this second test do not include them. So inside of this same group, we have designed another smaller group of tests that in this case are a little bit more focused because they are intended to answer to a particular type of cancer. We have made these tests for cancers or tumors that are a little bit more frequent in the population and they are well established. And the first one, or really well studied. The first one that we have to show you is the one that we have dedicated to colorectal cancer assessment. So this colorectal cancer test includes 18 relevant genes for colorectal cancer. And again, don't let fool yourselves by the number of genes getting decreased. These have been really well selected because the importance that they have and the clinical relevance that they have shown for colorectal cancer. In this list, we include for sure the genes included in the mismatch repair pathway as MLH1, MSH2, MSH6, and PMS2. But also, we include other genes that are really clinically relevant for other types of colorectal cancers, such as APC, MUTYH, or genes that are related to better selection in the treatment modality, such as mutations in KRAS or NRAS. That, as I'm saying, they can help us to better understand the type of treatment that this patient might be sensitive to. So the full list of genes, the 18 genes, you have them here. Also, another genes that I think it is important that you notice are SMAD4, TP53, and others. In whatever case, we are also able to check not only single nucleotide variants, but also changes in the number of copies of some of the genes. And the specimen requirement is a tissue biopsy of the affected tissue for sure. And we always recommend also a blood drawn for the patient so we can assay both somatic mutations and germinal mutations for those of genes. Also, particularly, we can accept only a sample of blood from one patient that might be interested only in assaying the risk of cancer associated to these 18 genes and only these 18 genes. So the value of the test is for sure, as I mentioned before, that you will be able to get a genetic profile of the tumor, helping to understand the classification of the tumor and better understand how this tumor might behave. Also to get much more guidance for the treatment selection, fitted to the patient requirements. And because the composition of the test, we might start thinking about if the patient fits into the requirements or not to be classified as a Lynch syndrome patient, and also another syndromes as the FAP related with APC gene or the MUTY8 associated polyposis syndrome. So the next one is the microsatellite instability assessment test. And we have decided to dedicate one test to this because the microsatellite instability has been in this last year proved to be a really well-defined marker to consider immunotherapy. Patients with high microsatellite instability are patients that end up responding really well to immunotherapy. So it has been established as a marker that in many different types of cancers might be really interesting to check. For sure, in colorectal cancer, so might be something that we might thinking as a complementary as a complement of the previous test, or we want to check this by itself because it might be interesting for other type of cancers. So as I was saying, the microsatellite instability is a biomarker that has been related with the response to immunotherapy. These microsatellites are indeed regions of the DNA that they are able to change the length, and this is a readout of how good or how bad is working the mismatch repair pathway. So when the genes included in this mismatch repair pathway, the ones that I just mentioned previously, the MLH1, MSH2, MSH6, or PMS2 are impaired, they are not, they are silenced or they are not functioning properly. This implies that the mismatch repair pathway do not work properly, and a readout of that is the length of these markers. So this is the first and the only test included in the whole catalog that is not performed through next generation sequencing. This is indeed a PCR-based test where we are able to detect this microsatellite instability in 5 target mononucleotide repeat markers that are broadly accepted and used for checking this microsatellite instability. These are the 5 markers that we will be able to check, and the value of the test is in here. That when we find changes in 2 or more markers, then we will say that we have high microsatellite instability. If we just find changes in the length of one biomarker, then we have a low microsatellite instability sample. And if we don't find changes, then we can say that there is no microsatellite instability in this sample. So the requirements in this case, it will be also a tissue biopsy from the patient from the affected area, and also a small tissue of the non-affected area, so we can check intra-patient the changes that might be on these markers. So as I was saying, and I don't want to repeat myself, this microsatellite instability has been proven a really good marker for checking how good might respond the patient to this immunotherapy, and has been also considered a criteria to verify that patients are indeed suffering from a Lynch syndrome. So it might be really interesting to check in some colorectal cancers, but also might be really interesting to check in other type of cancers such as gastric, endometrial, or also have been proven to be a piece of information important for non-small cell lung cancer. So moving forward, now we change a little bit the type of cancers that we focus our test on, and the first one is the Braca test. So this test is intended to check only the 2 genes of the homolog repair pathway, BRCA1 and BRCA2. These 2 genes, as probably all of you know, are well associated with different types of cancers, particularly breast cancer, ovarian cancer, and prostate cancer. This test is only intended, as I say, to assay these 2 critical genes or key target genes, And the way that is designed allows us to check the 100% of the exonic region of these genes. So we will be able to check the full coding region of those genes. Also, we go in the analysis 64 base pairs upstream and downstream of the gene. So we have also covering some intronic regions. Altogether, allows for over 99% of confidence of detecting somatic variants that happens in the 5% of the with the 5% frequency in the population, or even a little bit less. Again, we will be able to check not only nucleotide single variants, but also a change in the number of the copies of the gene, and also the complete loss of one or different exons of these two genes. We will require one piece of the affected tissue plus one blood sample, so we will be able to check for both somatic and germline mutations. And the value of the test is for sure knowing the mutational state of these two genes that has been clearly related to many different types of cancers, as the ones that I mentioned before, but also knowing if the patient is a carrier of a BRCA1 or BRCA2 mutation is the high value for the treatment selection. And this is because it has been shown that these patients are considered for PARP inhibitors treatment as a maintenance therapy, and they respond pretty good to that. So for those cases in which the BRCA screening is not enough and we want to go further into this homolog repair pathway and check extra genes, we have this BRCA standard test. In the BRCA standard test, we don't only check BRCA1 and BRCA2, but also another 18 clinically relevant genes. Here we have the full list, as you can see, not only BRCA1 and BRCA2, but also other relevant genes such as BART1, BRIP1, PALP2, B10, RAT family, and many others. All of those genes has been shown to have high implications to understand the treatment and the prognosis of different types of cancers, such as breast, ovarian, and prostate cancer, for example. Again, I'm not going to go with a lot of detail. We will have time to talk about it if you really want to. But for example, the assessment of TP53 has been proved to be a marker for knowing the prognosis in ovarian cancer. So all the genes, what I'm trying to say is that all of genes that have been included in here has been well thought to have a clinically relevant content for this type of cancers. So we will be able to check again single nucleotide variants, but also changes in the number of copies for those genes. And again, we will require a piece of the tissue biopsy of the tumor, plus also always recommend a blood sample so we can check both somatic and germline mutations. As I mentioned previously, in the colorectal cancer, we might accept in some cases only the sample of blood from the patient, just in the case that the patient is only curious or only wants to know the risk of suffering a hereditary cancer associated to these genes, and only these genes. And again, the value is the same as I mentioned before, being able to characterize properly the tumor, understanding the mutations and the classification and possible behavioral prognosis of the tumor, and for sure being able to make the selection of the treatment in the best fitting possible way for every patient. And then just changing a little bit of gears, and now we have the second group of a test that we have designed. These ones are intended to assay hereditary cancer syndrome risk. So this test that I'm going to show you in a minute is thought to assay people that even if they do not have an active cancer case, they might want to check the risk that they have to end up suffering one. This might be triggered by different concerns, such as a history of cancer in the family, or sometimes we just have patients that they want to know if they are subjected to risk of suffering some type of cancer associated to the inheritance. So we have a test for that, and this is the one that we have called Clarity test. So again, probably you already know all of this, but the hereditary cancer types are not the most frequent between all the cancers that we fight. only between the 10 or 15% of the diagnosed cancers are indeed inherited cancers. But it's important because these type of cancers are, by luck, one of the types of cancers that are best studied, are best characterized. So knowing that we are carrier of a mutation that might increase or risk of suffering one particular type of cancer might be really important for us, because in the end, information is power, and knowing that, as I say, we are carriers of a mutation that increases notably our risk of suffering a cancer can help us to take early decisions. Some of them might be, for example, considering early screening programs such as colonoscopy or mammography earlier than the general population that is not subjected to that type of risk. Also, if the medical provider, the specialist, considers it as an option and the patients agree to that, prophylactic measures might be taken. Or one of the things, or the pieces of things that I consider is really interesting in this case, is that knowing your risk of suffering a particular type of cancer is not only giving you information, is providing your whole family information. Because knowing that you are a carrier of an inherited mutation might have implication in the first line members of your family as well. So in a minute, I will show you the genes that are included in here. But again, in this case, we will start from a blood or saliva sample from the patient. We will be able to check these germline mutations, and depending on the gene, we will be able to assay single nucleotide variants, indels, or changes in the number of copies of the gene. And this is the composition of the Clarity test. We have selected 39 genes that are well documented to present or to show association with hereditary cancer syndromes. In here you have the full list. I'm not going to go ahead and detail all of them, but I put together here a small table trying to represent that we have a high coverage of well-known cancers associated to the inherited risk, such as breast, ovarian, endometrial, or prostate cancer. We also have a really good coverage for colorectal cancer risk, but we do not leave behind other cancer types that also have genes that has been strongly associated to have an increased risk of suffering these kind of cancers, such as gastric, pancreatic, or melanoma. So to sum up, as I said, the intention of this test will be to check for germline mutations in patients that, even if they do not suffer actively for a type of cancer, they might need to know if they are subjected to a risk or not of end up suffering a cancer. And finally, I'm going to go with the last group of tests that we are including here in this catalog, which are the liquid biopsies. So we think that liquid biopsies are not only the future of cancer genetics, but also the present of cancer genetics. And this is so because not only in research, but also in the industry, liquid biopsies are being pushed in order to be considered as a really relevant clinic tool. And this is because they have clear advantages versus the gold standard, or the strong gold standard to these days, which is the solid tumor piece of tissue, right, that we use for genetic screening. Again, not only because it has clear advantages, but also because the results that we are obtaining from liquid biopsies are really promising. First of all, we have a really high rate of concordance with the mutations that we are finding in the tissue. So this increases the confidence that we have in liquid biopsies and help us to keep pushing forward to use them as a real tool that has really clinical implication in the daily life of oncologists and patients with cancer. And as I was saying, the clear advantages that the liquid biopsy has versus the traditional tissue biopsy is that, first of all, is that a minimally invasive technique. So this implies that the patient does not need to go through surgery. We don't need to put together a group of surgeons and a whole team for doing that. So the patient just needs to go to the medical provider office and take the medical specialist will take a blood draw from it, and this causes minimal stress for the patient and also for the medical team. And because of that, it can be repeated along the time as many times as a medical specialist considers it. The second thing is one of the most important things, in my opinion, is that liquid biopsy is able to recover the tumor heterogeneity. And this is because, the weakness of a tissue biopsy is because the nature of the test, or the way that we obtain the tissue biopsy, is that we are pinching in a concrete region of the tumor. So we know that tumors are not a solid mass composed 100% by the same type of cells carrying the same type of mutations. We have subclonal populations that might carry different mutations that might have a really big impact in the treatment and the resistances that the patient might end up showing through the treatment. So we are losing that in many cases, taking just a tissue biopsy. But in the case of liquid biopsy, we should be able to recover the full heterogeneity of the tumor. And this is because in the blood, we can find tumor DNA coming from whatever type of cell that was once forming part of the tumor. And the third thing that I consider important to mention is that liquid biopsies allow us for temporal checking of the patient. So in this graph, we can see here just briefly, the green line is showing the ctDNA, the tumor DNA free in the blood, a limit of detection, and this blue line is representing the CT scanning detection threshold, right? So this black line is representing the evolution of a patient that after surgery was going through adjuvant chemotherapy, and as we can see here, the evolution of the disease has been negative, so it's experiencing a relapse. So through liquid biopsy and the detection of this cancer free DNA tumor in the blood, we will be able to detect that there is a relapse way earlier than with the imaging, because with the imaging we need that the cells or the mass acquires the size enough to be detectable. So we are gaining a lot of time by using liquid biopsies, and we know that in cancer, time is one of the most critical aspects. As long as we are able to detect them really early in the process, these give us better chances to get a better response to the treatment and a better outcome in general. So with that in mind, I'm just going to jump and show you the liquid biopsies that we are including in our catalog. And the first one is the pan-cancer liquid biopsy. And the consideration here is mostly the same as I mentioned previously for the tissue-related test. This is a test that has been designed in order to be able to assay whatever type of tumor, solid tumor, that we want to check independently of the tissue of origin. So this will be the one that we can use mostly for all the type of cancers that we might want to check. So in this case, we have included 52 clinically relevant genes for a wide variety of tumors. And with only one blood sample, we can able to recover both DNA and RNA, tumoral DNA and RNA free in the blood. So we are able to assay these all type of lesions from single nucleotide variants to change in the number of copies to fusion in these target genes, as I mentioned. I'm not going to go in detail with the name of the genes because you will have all of them available to you. And as you can see, again, we can find genes that are really important for treatment selection as EGFR, LB2, ALK, ROS, KRAS, and RAS, and all the gang. And just to mention that we have found high concordance, or this test have shown high concordance with solid tumor biopsy results, and they show a really great limit of detection. So the value of this test is that indeed they will help us to find the whole tumor heterogeneity, allowing us to find clones that might be resistant to a particular type of treatment. So if one treatment stops functioning, we can go ahead and check which is the mutation that is causing this resistancy in the case that is known. And also we can do a follow-up of the patient and detect this relapse prior to imaging techniques. Same as before, we have also designed liquid biopsy, or we have selected liquid biopsies restricted to the particular type of tumors that are normally the most frequent in the population. And the first one is the colorectal cancer liquid biopsy. In this case, we checked for 14 clinically relevant genes in colorectal cancers. So here you have the full list, and again, with one only blood draw, we will be able to assay different type of lesions in these genes. And again, I'm not gonna go in detail with all the lesions. I just listed here some of them that might be of your interest. For sure, I will be more than happy to go in detail with them if somebody has an interest of that. I'm just going to briefly mention that, for example, one particular gene that is interesting to be checked in colorectal cancer because has implication in treatment selection is KRAS. And we check here mutations that are affecting the exon number 2 that might cause resistance to anti-EGFR treatments. So we include some of the key targets that are considered in the routinary checking of these patients, but also others that might be interesting to know for the future of the patient. Again, high concordance with tumor tissue results and great limit of detection. And the value of the test is, as I mentioned before, being able not to only detect at once the whole tumor heterogeneity, but also to detect if there are mutations that are causing resistance to one particular treatment, and also provide a follow-up, a close follow-up for the patient, and detect this possible relapse prior to the actual imaging techniques. Same for breast cancer. We have a liquid biopsy intended for checking breast cancer. And in this case, the only thing, or the mainly thing that changes is the genes that are included in the test, which are again now 12 genes that are clinically relevant for this particular type of cancer. Again, one blood tube will be enough for us to check this list of genes and the different variants, pathogenic variants that have been associated to them. For example, I'm just going to mention a couple of them. We will be able to assay ERBB2 gene, in which mutations have been associated with sensitivity to anti-HER2 therapies. Also, we check another promising marker, which is ESR1, in which mutations have been associated with anti-estrogen resistance. And the list goes on. I just mentioned here some of them. And the value of the test, as I mentioned previously in the previous two ones, knowing the tumor heterogeneity, knowing if we have a mutation that might be triggering the resistance against a particular type of treatment, and make a close follow-up of the patient and detect these relapses before imaging. And the last of the test that we have here to offer today is the lung cancer liquid biopsy, specifically for the non-small cell lung cancer type. And this type of liquid biopsy, I think they deserve a specific mention because lung cancer is a specific or a particular type. As I mentioned in the introduction of the liquid biopsy, tissue biopsy is still the strong gold standard for cancer screening in tumors. But in the particular case of lung, liquid biopsy is gaining importance. And this is due, first of all, because the tumors in the lung are really difficult to get a biopsy, and sometimes it's not possible to repeat the biopsy and get extra tissue to check extra markers. So in here, it's even more important than before to get a full picture of the tumor heterogeneity at once, because we might not have material enough to continue doing biopsies, or sometimes it's just not even possible. All of that together, for sure, with the fact that this liquid biopsy has shown a high concordance with the solid tumor results, has made that now these liquid biopsies for non-small cell lung cancer are considered as a complement in the first line of diagnosis of this kind of tumors. And because of that, we have included relevant genes for that. Again, we have here 12 clinically relevant genes for this particular type of cancer. And I just want to mention, for example, that we have an extensive coverage of EGFR gene, where we will be able to assay deletion on exon 19 and other type of mutations that we know that are showing that the patient is going to be sensitive to these TKI inhibitors, but also we check for mutations that provide resistance through the, against this treatment. So we will be able to inform how is the way to modify the treatment to the in the second line. But not also EGFR. We also check, for example, fusions. One of the most interesting in non-small cell lung cancer are ALK fusions. The fusions in this gene end up producing a gene that constitutively is active, and it has been shown that actually patients carrying this type of fusions are indeed not carrying EGFR mutations. They seem to be mutually exclusive, and the type of treatment that is intended for these patients is slightly different. So again, at once we will be getting the full image of the tumor heterogeneity, guiding the treatment in the best way possible from the beginning to even if we have to make changes, and also we will be able to make a close-up of follow-up, of the patient and detect these relapses prior to they are visible by traditional imaging techniques. And with that, I just want to make a really brief summary, just because I've been talking for a while right now. So just to take you home, these are the main tests that I've been talking today. The first group were the ones intended to assay tumors through tissue biopsies, and we can provide two different types of pan-cancer assay. The one that includes the immunotherapy markers, and the one that is a little bit smaller, in case that we don't need information regarding to those two markers. And also we have tests intended to be specifically covering concrete type of cancers. Also, we have the clarity test that, as I mentioned, was the one related, or the one for assaying hereditary cancer syndromes risk. And then the group of liquid biopsies that I just mentioned in this last few minutes. And with that, I'm going to stop myself. And I just want to thank you again for giving us some of your time to be with us in this webinar. And I just want to let you know that I will be more than happy to answer questions right now or even in the future. You have here my contact and the way that we can get in contact. And with that, I will just leave Luis to continue from here. Thank you again.
Okay, thank you very much, Noemi, for the presentation. We have some questions here, but we ran out of time almost, so I will try to pick up a couple of them, okay? So one of them is regarding the average time to receive the results from Dr. Opan Abdul Majid. So I can separately give you the test list and including the turnaround times, but on average it's like 30 days, roughly, for most of the tests, okay? I can give you the accurate information. Just drop me an email at this address, luis.valino@bioarray.es, and we will provide the precise information. Okay, that was for me. Then for Noemi, more specific technical questions. I think you kind of addressed this, but just in case to clarify, the question is, how should I choose between the pan-cancer comprehensive assay and the pan-cancer comprehensive assay plus, these panels for solid tumor testing?
Yeah, okay, thank you for that question. Again, I think this will depends on the type of information that you need for the type of cancer that you are assaying. If you are assaying a particular type of cancer where you consider it's really important to check these biomarkers related to immunotherapy, then I will suggest to get plus version, because we give you a broad assay or a broad landscape of the mutations present, but also we give you these two key pieces of information. But sometimes the type of cancer that you are assaying has no implication, or these two markers might not be crucial to assay, so we can move to a smaller one, which is still really comprehensive and really complete, and you're gonna get a full landscape of the mutation, but without having enough information that is not gonna helpful for you on the practical case that you are handling.
Okay, thank you. Then another one regarding the liquid biopsy. Do I need to have information regarding a particular mutation in a patient in order to proceed with a liquid biopsy?
So the short question is no. Our panel has been constructed so we can check as I said, the genes that are clinically relevant for the particular cancer that we are assaying. So if the patient has history because the genetic screening of that tumor has been performed previously by a different biopsy, tissue biopsy, or a different liquid biopsy, and we have information regarding of the mutations that have been found, then yes, for sure we will take that into account, but it's not a requirement. Without not knowing those, we can also go ahead and proceed with the liquid biopsy as the way that we intended them.
Okay, thank you. Then I think we have time for another one. Good afternoon. How reliable specific is the liquid biopsy for relapse evaluation in breast cancer?
So as I show you before in the graph, not only for breast cancer, but for the majority of the cancer, solid tumors, the liquid biopsy is showing a much better threshold or much better limit of detection than the classical imaging techniques. So we will be able to check even only the amount of tumor cell-free DNA present in the blood. So we can do that as many times as we want to along the time. And in some point, we detect that the amount of DNA, the tumor DNA, is increasing in the blood, we will be able to see that there is a relapse happening. So we consider that this is a really good application of the liquid biopsy and can help the patient to understand that the evolution of the disease is not as positive as might not be seen otherwise.
Okay, very good. I think we have time for the last one. Good afternoon. Do you offer result reports in other languages besides English?
Yes. We can provide report results in many different languages depending on the requirements of the clinic or the hospital or the doctor that wants to get a specific test done. Is not a problem for us.
Excellent. Okay, so I think we are done. There are a couple of more questions that we can address, directly with the attendees because we ran out of time. And well, only wanted to thank you very much. Thanks to Dr. Noemi Ribes. Thanks to all of the attendees because for the nice questions as well. And we got quite a nice attendance today. And that's it. We will be happy to answer more questions via email if you require more information. And stay tuned for future webinars that we will be providing in the cancer genetics field.
Okay, it's been a pleasure. Thank you all of you for attending. Bye.
Goodbye.